Thank you. My name is Stella. I'm from Kenya. I mean, it's interesting to listen to this discussion about how you're moving away from out-of-pocket payment model of financing healthcare systems. Yet, in where I come from, like in Kenya, for example, is that we're trying to kill the community health model system and moving towards more of, in terms of financing, we're either having insurance-based, we're either also having the out-of-pocket, and this is just actually being driven by the market forces and being driven by privatization of healthcare. How then do we, as we sit here discussing about global solution, and it actually touches across the globe, and how do we carry some of these lessons and ensure that even as you're coming in, as investors are coming in within developing countries, that the same models are actually being adopted instead of pushing towards market-driven forces of healthcare systems?
That is a panel in itself.
Yeah, that's a great question. I'll start.
I'm thinking about my answer to that.
You know, I think that we will not really see, and I would put Kaiser Permanente in there as well, the total transformation of healthcare until we've also redesigned the economics of healthcare. And the idea that we can stand up and say truthfully that we have the most efficient, effective healthcare system on earth, and we think the next set of solutions is how to add to that, I think we would be kidding ourselves, both as a health system and as a country. I think that part of our work ultimately is in the empowerment of the people who are actually paying us for the things that we do, but done in a way that the incentives are aligned for the right behaviors and outcomes that we need to do. The fact that we haven't even figured out how to really tell you how much we're charging as an industry for what you are actually paying for is a great example of how far behind we are as an industry, right? And there's no such thing as, and there's no such thing as we cannot do it. In fact, we're going to prove it one day at Kaiser Permanente that really puts it in the same terms as a true consumer going in for anything else. That's unstacking a lot of things in the industry to better understand that. I think the second thing is there's a big difference between access to coverage and affordability of access to coverage and access to care and the affordability to access of care, right? And we deal in this country where people are trying hard, paying money to afford access to coverage. But then when they need to interact with the care system, they discover there's a big gap in the affordability of how do I now get the care. Until we solve those two things, we are a long ways from transforming healthcare in this great country.
And you know, Bernard, you said that very well, by the way. But you know,
bring it home. Bring it home.
Well, no, I'm going to give you an example, okay? Because you know, in our shop, we just had a discussion about what is transparency and how do we make transparency actionable. And I'll give you an example of something that we're in the process of rolling out because there's been so much rhetoric and discussion about drug pricing. But yet, think about that physician when he or she is writing that prescription. That doc has no idea the out-of-pocket cost of that medication for their patient. So we're in the process of embedding, that patient's plan design, in the patient's EHR. So when the physician goes and, puts that prescription in, assuming they're prescribing it electronically, and today about 80% of all scripts, are prescribed electronically, he or she will be able to see the patient's out-of-pocket costs and up to 5 alternatives and the cost associated with each. One of the things that we're seeing is physicians are switching to a lower cost alternative 30% of the time with an average savings to the patient of $70. And I think, Bernard, that's a great example of what you're talking about.
Yeah, absolutely.